The rotator cuff is made up by the supraspinatus, infraspinatus, subscapularis, and teres minor muscles. These muscles make up the dynamic stabilizers of the glenohumeral joint. The rotator cuff muscles combine with the fibrous capsule of the glenohumeral joint, providing stability and protection to the shoulder by holding the head of the humerus in the glenoid fossa of the scapula through compressive forces. The subscapularis is the only muscle of the rotator cuff that does not rotate the shoulder, as the supraspinatus adducts the humerus and controls the correct alignment of the humeral head in the glenoid fossa. The glenohumeral joint is placed under a great amount of stress during overhead movements such as baseball pitching and tennis serves, as well as during contact sports. The supraspinatus is the most commonly injured muscle of the rotator cuff. Injury can be caused by repetitive macrotraumas or macrotraumas related to contact. Static stretching of the posterior shoulder muscles assists in the regaining of internal rotation lost. This reduction in rotation is due to the tightness of the posterior shoulder musculature. Releasing this tightness of the posterior shoulder, along with chest muscles such as pectoralis major, can assist in the increased range of motion of the shoulder joint and rotator cuff muscles. The sleeper stretch has been proven to effectively isolate and stretch the posterior muscles of the shoulder. When lying on one side, it aids in the scapular stabilization. Launders 2008 suggests that the stabilization of the scapula during this movement is what makes the sleeper stretch more superior over other stretches that isolate the glenohumeral joint. By implementing the sleeper stretch along with the use of TheraBands for exercises such as lying, side, external rotation, high to low rows, and the lawnmower stretch, can assist in the prevention of rotator cuff and supraspinatus tears. The exercise increases the range of motion of the shoulder joint and increases the internal rotation, as well as relieving posterior shoulder tightness. Stretching of the posterior musculature will reduce the level of muscle tightness and promote the posterior translation of the humeral head during overhead movements while increasing the range of internal rotation. A stretching protocol should be implemented into every training session after the warm-up and before strength training to increase the flexibility and range of motion.
Scaption with internal rotation. You're going to stand with your elbow straight and thumb down. You're going to raise your arm to shoulder level at 30 degrees angle in front of your body. Do not go above your shoulder height. Hold for 2 seconds and then lower slowly.
So the sleeper stretch is performed by laying on the affected shoulder with the elbow bent at 90 degrees, taking the uninvolved arm, grabbing the wrist, and bringing the hand down to the table until a mild to moderate stretch is felt.
When developing a shoulder strengthening program, the 4 P's should be emphasized: glenohumeral protectors, humeral positioners and propellers, and scapular pivotal muscles. Injury prevention via the strength training should focus on building up the strength of the rotator cuff muscles, such as the supraspinatus, infraspinatus, teres minor and subscapularis, and scapular stabilizers such as the trapezius upper and middle and lower, the minor and major rhomboids, and the serratus anterior. The supraspinatus, along with the deltoid muscle, abducts the shoulder while maintaining the position of the humeral head in the glenoid fossa. The supraspinatus muscle can be strengthened isotonically through a military press exercise, scaption with internal rotation through an empty can exercise, scaption with an external rotation through a full can exercise. These exercises are proven to be effective in strengthening the supraspinatus muscles. The full can or empty can exercise has been shown to increase activation and strength of the supraspinatus muscle. However, if this exercise is done incorrectly, it can lead to impingement injuries. Muscle activity is increased during these exercises through the internal rotation of the glenohumeral joint by increasing the muscular tension throughout the range of motion. While the full can and empty can exercises elicit similar muscle activation, it's demonstrated through EMG analysis of the supraspinatus. The full can exercise has a reduced risk of impingement compared to the empty can. The full can exercise should be included in rotator cuff strength programs to increase the supraspinatus strength. The infraspinatus and teres minor muscles can be strengthened through horizontal abduction with external and internal rotation, along with pure external rotation and abduction exercises. Deceleration throwing exercises and push-ups with hands together have also been shown to strengthen the muscles. For the subscapularis, along with other rotator cuff muscles, effective strengthening exercises include the military press, scaption with internal rotation, flexion, and abduction. The scapular stabilizers are involved in the rotation of the scapula for the glenoid fossa to be used in the correct position for the movement of the humeral head. The strength of these muscles are very important for overhead motions, as a significant amount of force is placed upon the humerus, causing it to reach immense angular velocities. Inadequate strength of these muscles can increase the risk of sustaining a serious shoulder injury. The major muscles of the shoulder joint also require adequate strength. Caution when targeting these muscles in a strength program. If they are strengthened too early compared to smaller muscles, it can overpower the shoulder joint, leading to substitution and asynchronous motions throughout overhead motions, such as throwing. It is suggested that strength exercises for the pectoralis major, deltoids, and latissimus dorsi should begin approximately 2 weeks into the program to allow for even strength increases for the large and small shoulder muscles. The exercises shown in Table 1 are effective in strengthening the largest muscles of the shoulder. Research states that the TheraBand use is an effective tool in injury prevention or rehabilitation protocols for overhead throwing movements. It has been shown that TheraBand exercise patterns of proprioceptive neuromuscular facilitators, or PNF, can increase the eccentric strength of rotator cuff muscles, including the supraspinatus muscle. However, this method of strength training does not correlate well with the overhead throwing velocities. It is much slower than a baseball pitcher or tennis player's arm during a throwing or serving motion. Even through TheraBand work increasing eccentric strength of the shoulder musculature, the application to sport performance may not have a large impact. Researchers began investigating ways to increase shoulder strength at high speeds. Upper extremity plyometric training has demonstrated an effective method in increasing overhead throwing performances. Carter et al. 2007 proposed training shoulder muscles with strong eccentric contractions of the external rotator muscles. This method is shown to assist in the reduction of the shoulder injuries. What makes plyometric training effective is the involvement of the stretch shortening cycle that relies heavily on the rate of stretch and the force development. The stretch shortening cycle is comprised of 3 phases: eccentric, amortization, and concentric phases. The faster the amortization phase of movement results in an increase in elastic capacity of the muscle tissue, allowing for an increase in velocity and force production. A plyometric training program should be progressive. The Ballistic 6 program has been examined in the current literature in its ability to increase the muscular strength and velocity in overhead throwing. The Ballistic 6 program consists of 6 exercises that stimulate an overhead throwing motion, such as pitching or a tennis serve. The program is designed to progressively increase strength over 8 to 10 weeks with gradual increases in training volume to produce strength and muscular endurance of the shoulder joint and rotator cuff muscles. The design of the Ballistic 6 program is 3 sets with 10 repetitions of each exercise, with 30 seconds of rest between each set. This volume is consistent for the first 3 weeks of the program. It is then progressed to 3 sets of 15 reps with 30 seconds rest in between each set for another 3 weeks, and then the final stage progresses to 3 sets of 20 reps for each exercise. Throughout the use of the Ballistic 6 method, throwing velocities have been shown to increase with plyometric exercises. The exercises closely mimic the sport-specific movement and speed and stresses placed on the shoulder joint during pitching or serving motions.
The use of a pre-season screening tool is effective in early detection of injuries and injury prevention. An effective screening tool developed by Smersey in 2007 consists of injury history, subjective complaints, observations, palpitations, range of motion, flexibility, manual muscle testing, functional testing, and special testing. When examining overhead throwing athletes, it is common to see postural abnormalities that can lead to incorrect throwing mechanics, potentially resulting in injury. For correct throwing technique to be achieved, flexibility of the glenohumeral joint is required. Screening procedures for throwing athletes can consist of internal-external rotation, shoulder flexion, shoulder abduction, and horizontal adduction and scapation. Screening should also examine the athlete during specific movements such as throwing a baseball, as throwing mechanics often cause injury. Close examination of the cocking, acceleration, and deceleration phases of throwing is essential, as these phases cause an increase in muscular activity. Along with throwing analysis, core assessment should also be examined, as the core is crucial in the rotation of the trunk during the throwing motion, along with affecting the position of the shoulder joint. A screening formula for the throwing athlete. Kibler in 2006 demonstrated in his studies how to look out for problems and where they arise, and what is classified as good form during a pitch. The single leg stance can be implemented, the single leg squat. Then that progresses to a single leg stance or a single leg squat with trunk rotation. He then adds resistance to this movement. In the lower back, we are looking for a stiff spine where little movement occurs. The same can be said for the trunk. Other than that, the rotation of the torso is evident and there is nothing else moving.
A systematic review of the literature, followed by a meta-analysis by Cliché et al. 2015, revealed that only half professional athletes post-rotator cuff surgical repair return to sport at the same level of play 4 to 17 months after surgery. This is significant, as it establishes that a professional player cannot count on surgical repair of the rotator cuff to return them to sport at the same level. And the repair phase of rehabilitation may take at least 6 to 8 weeks, and the tendon bone interface can continue to remodel for at least 9 months. Accordingly, a vital and complex stage of the rehabilitation is the return to play phase, as this final stage of the progression and will significantly impact the athlete availability and determine the risk of re-injury. Return to play can be defined as the medical clearance of an athlete for full participation in sport training and competition without restriction. Return to play aims to safely and efficiently return the athlete to full function and place the injured structure above the level of strength, range of motion, and functionality prior to the injury. Previous research has described effective return to play protocols to contain components that seek to confer anatomical and functional healing, health and participation risk status, and further ensure that the athlete is psychologically ready to return to sport. Therefore, as a basis, each return to play protocol should be individualized, as every supraspinatus injury circumstance is different, with multiple factors being involved with each patient. These include age, injury mechanism, the dominant or non-dominant extremity, the extent of the pathology, whether there are any associated pathologies, sport activity demands, and level of performance. The optimal return to play treatment of supraspinatus tears is not known, although a graded, progressive approach to athlete rehabilitation will enhance the ability of return to play rather than applying a time restriction. To ensure the athlete is ready to return to play, we'll have to meet individualized and sport and position specific progression markers to progress in the return to play process. Andrew et al. 1985 and Kibler and Siassi 2008 suggest an athlete who returns to sport too soon can alter arm swing and throw mechanics and risk injuries not only at the same shoulder but also the elbow, hip, and spine. The markers athletes have to reach are objective goals that can assist high-performance staff in determining unbiased and safe return to play. Unfortunately, there are very limited proven objective markers for sport-specific supraspinatus or rotator tears in return to play protocols. However, there are general guidelines and clinical and functional tests that are considered to be valid and reliable in assessing if an athlete is ready to return to play and for the known risk factors of re-injury of the supraspinatus tears. The general guidelines for supraspinatus and rotator cuff return to play protocols require athletes to be pain-free in the shoulder during rest and activity, to have bilateral muscular strength at or near pre-injury states, to have near to full range of motion of the joint in active and passive movements, to be non-tender and without swelling, to have functional athletic ability and confidence. Functional testing can examine these return-to-play markers, as it allows the status of the athlete in relation to sport-specific actions to be tested. An appropriately designed battery of functional tests will facilitate and allow integration of sport-specific muscular strength, range of motion, proprioception, endurance, and confidence. Miller and colleagues, 2009, suggests that each test within the battery should effectively mimic the forces and stresses that will be experienced by the athlete in a competitive situation. To assess pain in the supraspinatus and/or rotary cuff in a high-performance environment, the empty can test can be implemented, as a positive test indicates a tear to the supraspinatus tendon or muscle and also gives a good indication of the pain. Toll suggests the empty can test to have a high test sensitivity, and Park and colleagues 2005 suggests the test to have high specificity. The video to follow will demonstrate the empty can test. To assess bilateral muscular strength of the supraspinatus and/or rotary cuff in a high-performance environment, the full can test offers a reliable and valid measure. The full can test can determine weakness in the supraspinatus and also detect pain. The full can test has further demonstrated high test sensitivity and specificity. To follow will be a video demonstrating the full can test.
We'll ask the patient to do is to raise their arms into about 90 degrees of abduction. We'll then move them again into 30 degrees of horizontal adduction, placing their arms in the scapular plane. The thumbs are up, indicating that this is the full can test. The clinician will then come in front of the patient typically, but for the purposes of this video I will come behind my patient and I will apply an equal force through both arms. Weakness or pain on the symptomatic side is indicative of a positive test.
To assess the range of motion in the supraspinatus, a complete observation of in front and behind the athlete must take place. The supraspinatus helps the deltoid muscle initiate abduction of the arm at the shoulder joint and helps stabilize the shoulder by drawing the humerus towards the glenoid fossa of the scapula. Fagema and colleagues use the painful arc test, which in the subject is asked to abduct the arm. The clinician can apply resistance to this movement to test for extra pain and also assess flexibility. Pain in this motion can reveal tightness or stiffness in the supraspinatus.
Now we're going to do the painful arc test. You just stand and talk to the person while they do the test, and you say this: lift your arm to the side slowly and stop if it hurts. And if it hurts, it's going to hurt right there, somewhere between 70 and 110 degrees. Then you say to the person, continue lifting your arm and tell me if the pain goes away. And usually starting about there, and she keeps going, and the pain usually goes away, and they smile, and the pain's gone. And then when they come back down, sometimes they feel the pain again starting here. This is the painful arc area, starting about there, coming down, 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 till about there, and that's the painful arc. So put your hand down again. So the arc means that there's no pain. Lift your arm slowly again. There's no pain in the first part of the arc. There's pain in the second part of the arc on the side. And then there is no pain when she gets above there. And that's the painful arc. It means that something is being squeezed or pinched when it's in the middle of that arc. And that's the painful arc test.
A functional measure is required to determine if an athlete can return to play. Exposing a throwing athlete to throwing at high intensities will allow to mimic in-game performance. Being able to measure one's ability before injury and after injury is a precursor to return to play. If this cannot be done, alternatively, we can use objective norms from other studies. A study by Latruis and colleagues showed that increased strength can result in increased throwing velocity. So I set up a field of 2 markers, one side being the pitcher, the other side being the fielder, a third person being the timer. The time begins as the ball leaves the thrower's arm. The time stops when the ball enters the catcher's or the fielder's glove. Then a velocity formula is used, a simple one like speed equals distance over time. And an increase in speed means that an increase in strength, meaning the athlete is ready to return to play. Another instance we can use is throwing distance of the athlete, which can show increased performance and also increased strength in the shoulder.